has started.
Hello, everyone. Good evening, everyone. Thank you for joining us this evening. We want to welcome you to our webinar, very specially put together to address the challenge of maternal mortality in Nigeria. We want to know where you're watching, so if you'd be kind enough to please share your name and where you're watching from in the comment section. We'd like to know where our audience is joining us from, how you got to hear about this conference or this webinar, and why you decided to be a part of it. But something as simple as your name, where you're watching from will do. I'd like to go through the chat and just understand the people that we're interacting with. So if you can be please kind enough to drop your comments in the chat box, I would really, really love to especially recognize everyone. But just to say thank you for just being here is proof that you're particular about reducing the rate of maternal mortality in Nigeria. We certainly would love to have that conversation with you. We're starting off in 1 minute. We just want to wait to make sure that we can have more people join, but I can see the numbers going up. Maternal mortality is an issue that concerns everyone. It's something that we need to be looking at. So we want to say thank you. I'm just going to check the comments and see how many people we have joining us. Okay, thank you very much, Dr. Oyewole Asowata from North Carolina. Thank you very much for joining us. Also, at some point, we'll be taking the questions. Just a few house rules. We have the question and answer tab at the top right corner of the screen. So if you'd like to drop your questions, at some point during today's event, we will give you the opportunity to ask your questions. So please do well to drop your questions in the chat box. But I will be taking the questions much later. But just to also recognize our partners here at MRH Collective, just to say thank you. We have some of our partners here who are very key to the work that we're doing in reducing the rate of maternal mortality in Nigeria. And we get to hear from them. We also have people who have been a part of this and benefited from this initiative. So we would love to take live testimonials at some point. We'll try to work within a short duration. So much to do, so little time. But today we've come to address one of the most critical health concerns, and we want you also to be a part of our social media. So please, when we're done, we'll announce how you can be a part of our social media as well as being a part of the work that we do. But let me see if I can take one or two people. Thank you, Dr. Joy Adeshina, joining from Nigeria. Priscilla, we see that you're saying the chat has been disabled. We will ensure that our media team quickly fixes that so we can get more comments and chats from here. All right. Once again, I want to warmly welcome you to the Maternal and Reproductive Health Collective, popularly known as MRH Collective's webinar. And today we'll get to talk about why this is an important conversation to have. We'll get to speak with our founder, who is in the room right now, and she'll be speaking with us shortly, as to the vision, why she decided to establish MRH Collective in 2007, what the drive was for, what inspired this journey to where we are today. But before we get to speak with our founder, let's take a look at a video and then I'll do a proper introduction of our founder. But thank you once again for being here. Let's now get to take a look at her video and then I'll welcome her for our first Q&A.
Preventable complications. In 2020 alone, it was estimated that 82,000 women died from pregnancy and childbirth in Nigeria. Many factors contribute to this. Clinical factors such as excessive bleeding immediately after childbirth, hypertensive diseases of pregnancy, infections after delivery, and unsafe abortion practices. But there are also social factors. Delay in making a decision to seek care, delay in accessing the care due to transportation and other access issues, and delay in receiving quality care at the healthcare facility. It has been found that a large number of the women who die do so at delivery and immediately after delivery, and would have survived if they had skilled healthcare presence at delivery. Through our community-led programs, Maternal and Reproductive Health Collective, aka MRH Collective, links pregnant women to health facilities, supporting them to ensure access to care at delivery. We have reached thousands of women who have delivered close to 8,000 babies safely. Each life saved puts a smile not only on their faces, but on our faces as well. Please join us to impact more women in 2025. Your donation will help us expand our programs to more communities and save so many more lives. MRH, saving lives.
What a beautiful video there to set the context. Really great video there that sets the context for why we're doing what we're doing today. We believe here that every single life, MRH believes that every single woman deserves to get safe treatment, to be treated with respect and regard. Just to double check, I hope everyone can hear and we're not having any audio challenges. If you can, please signify in the chat box saying we can hear clearly and there isn't any form of challenge whatsoever. All right, great. So I certainly believe that that was a great way to set the context for tonight's conversations. Thank you very much. To set the context for tonight's conversations, we believe here at MRH that every woman deserves safe, and to be treated, safe treatments, respectful treatments, and that it should not be seen as a privilege. Maternal health should not be seen as a privilege, but it is a right that every woman is entitled to. And now to lead us through the conversations and sort of a question, Q&A between myself and our founder, let's get to see the mind of her vision for MRH, why she started this journey, where we're headed to. And because if we're welcoming you to be a part of what we're doing at MRH, it's important and imperative that you understand what our vision is and how you can be better aligned with that vision. So it's on that note that I would like to welcome our CEO, our founder. She is a professor of obstetrics and gynecology in the College of Medicine, University of Lagos. She's the founder, chairperson of MRH Collective, a non-governmental organization with a mission to provide the highest quality of health services for women and girls in low-income and marginalized communities. With over 120 publications, she has attained national and global recognition for her research in maternal health. She's lead investigator of several research projects with grants from TED Fund, Nigeria, NIH, USA, and the Gates Foundation. She had her first medical degree from Obafemi Awolowo University, Nigeria, her doctorate from the University of Nottingham, UK, and is a fellow of the Nigerian Academy of Science. She's also the director of the Center for Clinical Trials and Implementation Sciences. Her passion for women's health led her to the creation of MRH in 2007. I was privileged and opportune to hear her speak and hear the passion for the work that she did at another event that I moderated some weeks back. And I could say that it was such a very inspiring session that she had. It's my joy to ask. I want to see the virtual hands clapping in the chat box as I welcome the founder, chairperson of MRH Collective. Please welcome with me Professor Bosede Bukola Afolabi. A round of applause in the chat box. I want to see the hands clapping for her. Good evening, Prof. It's good to have you here. Thank you very much for the great work that you're doing. Let's see the applause is coming, everybody. Let's see her. Good. I love the energy. Chat box. Good to see you, Prof. First of all, I want to say well done. You're such an inspiration to women around the world. We had the I heard you speak for the first time at the last event that I moderated, where we're also talking about women's health, and it was just inspiring to see how much research, how much work you've put behind. It wasn't just about MRH Collective. We're talking. It was your passion, just seeing your passion for bringing an improvement to women's health. So first of all, thank you very much and well done.
Thank you so much, Olive. Wow, I mean, you're so great at what you do. I mean, it's almost like a live event, the way people are engaging. Thank you very much. And you make a lot of difference. Thanks a lot for agreeing to host us. Thank you.
Yeah, thank you. It's really great to be here. And I was sharing with you before we came on how this was personal to me when I was asked, and it was a no-brainer automatically because I had shared how last year I lost a friend to, I mean, it's sad to say, but childbirth, and that we're still having this kind of experiences in 2025 is such a sad but true reality. But let's get your perspective as to why you decided to start MRH in 2007. Was it from a personal experience? What inspired from the foundation, what inspired MRH Collective?
Thank you so much, Olive. So I'll keep it short. I've always been very, very passionate about, women's health. And that's why I decided to do obstetrics and gynecology. I wanted to do everything so quickly. So after finishing my housemanship in Louth, I did my medical degree in Ife, like you mentioned. Did my housemanship in Louth, and then immediately went to the UK to specialize, planning to do, to return immediately I finished specializing, which I did. 5 years later, I was back home and I got into the College of Medicine because I felt that was how to better affect public health lives, as in the women that really need the care. I started off there, was, working year in, year out, and I realized that there's so many women that are coming in from the community when they're already, almost at death's door, in extremis. They come into the hospital at that time and we lose them. Some we manage to save, thankfully, but quite a few of them, we also lose them. And I realized that the actual answer is in the community, not necessarily in, the hospital. Yes, we're saving some lives in the hospital, but if we can prevent these deaths and these illnesses in the community where the women are, where they come from, then that would make a better difference. And that's what made us decide to found MRH Collective. We're in the teaching hospital, we're seeing one woman at a time. In the community, you have the capability to affect so many women, so thousands and hundreds of thousands of women. So that was the reason.
Thank you very much for seeing a problem and deciding to create a way in which everyone can be a part of the solution. And much later, as we're progressing with the show, I'm sure that we'll get to let everyone here know how they can be a part of this. But in your experience so far, how would you say Nigeria has prioritized maternal health? Would you say that there's been an improvement from what you've seen ever since you came in on the scene? Or would you say that it's been a downward trend? What has your experience been?
Unfortunately, since I started working as a obstetrician and gynecologist almost 30 years ago now, about 28 years ago, things remains more or less even. Every year in, year out, we keep saying the same thing, maternal mortality figures are high, maternal mortality figures are high. These last few years, from about 2020, thereabouts, it's come to a head because we've actually reached we are the highest, in the world in terms of numbers of women because of our size. In terms of the ratio, we're the third, but we're after Sudan and Afghanistan, which is really awful. So there hasn't been a lot of, change or difference. There have been efforts. I can't, say that the government hasn't tried, but it just hasn't hit the button, hit the right spot. Recently, though, there has been a really big effort by the government. It's just started, and with the Ministry of Health, Federal Ministry of Health, called the MAMI, and we're hoping that will make a difference and will key into a lot of all these community programs and efforts so as to make a difference, a lasting difference.
Say that we have the highest number in the world and that in terms of ratio, we're the third highest. What would you say are the factors that contribute to it?
Mainly, so there are many factors. Clinically, we know that it's, bleeding from childbirth, which we call postpartum hemorrhage, a blood pressure condition of pregnancy called preeclampsia, where the blood pressure is raised and there are some other problems with different organs in the body, infections, sepsis, problems with abortion, as well as problems with, labor and delivery, like when the labor gets obstructed especially for women who stay at home or go to traditional birth attendants to deliver. So those are the clinical reasons. The social reasons are women not making the decision, not having the agency, that is the chance to make their own decision to seek healthcare when they need to. So they have to rely on, other people, including their husbands, their partners, their relatives, as opposed to them being the ones to make the decision. So that they don't make the decisions necessarily on time. Then when they do make the decision, making their way to the hospital. So access is a problem, either because of the area they live in or transportation issues. And then finally, sometimes also they get to the hospital and they're so ill that they can't get good enough care, or the care there is not optimal. So those are some of the social reasons. There are different reasons we also found with some of the work we did in the community, a project called the Yaloju. We found that a lot of women, part of the problem is that the access issues, they worry about the attitude in the health system, as well as cost. Those things are all important, and they also apply to causing these problems.
I mean, speaking about cost, so for those who don't know, I work on TV. I host a show, a political show, current affairs topical show every morning, Monday through Friday. And on one of the segments on the show, we spoke about a woman who unfortunately passed because they didn't have money to I think the child needed a cesarean section. They needed a cesarean section for the child to come out, and they needed about 500,000, if I remember correctly, and they didn't have that, and the woman died. So money is a very huge part, is a very huge factor, because maternal health care is not necessarily cheap. And which is why I think that it's important that everybody keys into what we're doing to make it affordable and accessible to as many women as we can. I think there's also the cultural angle to it and the social angle to part of the challenges that we face. I've heard people who say that women, and I've had quite a number of people who say, it's normal birth and cesarean section. And I say, no. So can you maybe speak to the role that religious and social biases have as to women's bodies and how women should bring forth children, and how they think that only women who have vaginal births are strong women?
Olive, even me, an obstetrician and gynecologist, I remember when I told my mother that, I'm going to have a cesarean section to have my daughter because she was breech presentation. The minute I said cesarean section, automatically she just said, which means God forbid. My very educated mother of a very educated daughter said that. That was just the automatic reaction she had. Of course, she came around, she had to. But the point is that, unfortunately, some people have this feeling that cesarean sections are, dangerous and terrible, and they show that you're not a woman and all that. And it's very prominent in our environment. So there's that. And there's also that issue of women not, this cultural thing, just like you rightly mentioned, that you should have your children at home the way your grandmother and the great-grandmother, had those children. Some people still have those, hard-held beliefs, sorry. And it's a very hard thing to break. But it's been noticed that if you educate women substantially, and you also make the access in terms of cost, for example, and location relatively free, they will go eventually. So it just needs continuous education, continuous advocacy, especially with the relatives and not just the woman. It takes a village. So we do have to make those extra efforts. Yeah.
It is really a collective effort, and which is, I think, the work that MRH Collective is doing is really fantastic work. Now we've talked about the challenges, the factors that fuel these challenges. Let's talk about the solution. I want you to speak to the Miles model and how you think that this has transformed communities, and how we can all be a part of it.
Thank you, Olive. So I mentioned the Yaloji, which was one of the first projects we did, where we went into the community to find out, to try and gather information in the first instance about why women weren't delivering in the hospital. And then we also know that, there's a lot of these deaths occur during the childbirthing process. Most of them occur during the childbirthing process and immediately after. And from the findings of that project and, these other knowledge, we created the Mama Base using the Miles model. And what the Miles model is about is, Miles, M-I-L-E-S. M consists, stands for mapping using data, primary and secondary data, mapping the areas where these women, where the vulnerabilities are, where the urban slums, where we have the higher or highest numbers of, deaths or population and, poor maternal indices. So after we've done the mapping, then we identify the actual women that we're going to, bring into the program and also identify the community mobilizers and health workers in that environment. So we have the women that we know, are vulnerable and need, support. And we also have the community health workers who are mobilizers, who know them, who live in those environments. L refers to linkage. We link, after identifying the women and identifying the community health workers and mobilizers who would assist, we link them to care. So the community health workers and the community mobilizers link these women in these vulnerable areas who can't afford or who have poor education or who have poor knowledge to the primary health centers near them. And also let them, link them to the primary health centers near them so that they can get, appropriate care, and let them know that they have to register there and help them to register and follow them up. E is to educate. We educate the women on the importance of registering and delivering in, safe healthcare systems. We also educate them on good, healthcare practices, infection control, the fact that it will be good to have the immunization afterwards for the babies, as well as family planning. Just give them basic education throughout that process. And both during the outreaches and the community health workers and through SMS messages, we give them all that information. And S, finally, is the support aspect. We support these women throughout the journey. For those that can't afford it, we pay for, in fact, even some emergencies, we actually paid for quite a number of cesarean sections for emergency treatments. We also pay for their registration in the health centers for those that need to be registered, that need to pay for registration. We paid for tests, and we also gave some incentives to them. So support, it was quite a big part of it. And also, we also leveraged on the insurance system that Lagos State has, because Lagos State actually has a health insurance system, and some of the women were able to access that, but that was part of how we linked and supported them. So it's a whole full range model, and we found it's quite useful.
Right, Miles, mapping, identification, linkage, education, and support, really full chain. So it's more like a holistic approach. And how would you say that this has helped in reducing the rate, the percentage of maternal mortality so far?
Well, in Lagos State, and with the very big support of the government there, we were actually able to register between 2023 and 2024, like a 1-year period. We set out to register just 5,000 pregnant women, and we ended up registering 7,883 pregnant women. And we followed them up. We have their data, because Mama Base, part of why it's called Mama Base is because it's a registry. It's a database for these women, which we hope to also be able to leverage to help improve healthcare going forward for these women. When we mine the data, we can get so much out of it and be able to show, where we need to do different things. So with the 7,883 women registered, we lost
9 of them. One death is terrible, so 9 is also is really, really sad. But the point there is that this was like a 99.9% survival rate. The normal ratio of maternal mortality, depending on the figures you use, if you look at the WHO figures for Nigeria, is 993 per 100,000. If you look at the National Demographic Health Survey figures, it's 512 per 100,000. With Mama-based Miles model, we got it down to 123 per 100,000. So
I
that
think this
was
is
really huge.
Yes, I want to see the applauses in the chat box. That's great work.
Yeah.
Drastic reduction of the numbers. And I know that there is a bigger target for 2025, and I'll have you speak to the target. Then we will come back to talk about what role we have to play. But just as quickly as we can, what's the target for 2025?
2025, the target is 15,000 women, 5,000 of them in Lagos and 10,000 in Kaduna State, because we're moving out of Lagos and we're moving to places where we also have a high incidence of maternal deaths.
That's brilliant. Thank you very much for this. And great. I'm seeing the applauses in the comment section. Thank you so much for this work. I mean, again, reinforces the work that MRH and the belief that MRH has, that every woman, regardless of her income, regardless of her location, regardless of her social class, is entitled to safe and respectful healthcare, and her life and her health should be prioritized. I'll come back to speak with Prof. some more, but just to also mention that these numbers and these figures that we're able to achieve, it's because we have people who believe in the work that we're doing at MRH. We have our international, people who collaborate with us internationally. We believe that when you want to go, they say when you want to go fast, go alone, but when you want to go far, go with someone. And we do this not by ourselves. There are bodies, individuals, organizations that have partnered with us to be able to ensure that we continue to do even better work. And we'll get to hear from one of them. She's the Global Vice President of Integration at the Clinton Health Access Initiative, CHAI, and the Country Director of the China Nigeria office. She's also the Interim Regional Director of the West and Central Africa region. I'll have her come speak to us shortly. And then again, I will come back to Prof. So thank you so much, Prof, for that fantastic Q&A session. So please let's give Prof a round of applause. And in the same breath, give a round of applause to our representative from CHAI, Dr. Olufunke Fashawe, as she comes to share with us a few thoughts before we bring in our next speaker. Prof is still here. So let's see the applause again in the comment section. Thank you very much, everyone, for being such a wonderful audience. I feel like I can hear your energy, not just see it in the chat. Let's bring in Dr. Fashawe to please speak to us briefly about the work that, testimonial, to share some sort of a testimonial.
Thanks very much, Olive, and hello, everyone. Good morning, good afternoon, good evening, depending on where you are. So, I mean, we've worked with MRH Collective now since 2023, exactly 2 years ago when we really started to work together as partners. Our first project was collaborating on the ongoing primary healthcare digitization efforts by the Lagos State Primary Healthcare Board. And our partnership has focused on combining program implementation with research-driven innovation. So while CHAI focuses on strengthening the health systems, thinking through the intervention, supporting governments to strategically design their programs, MRHC has been our design and independent evaluation partner because of the strong research expertise that they bring. And as you can imagine, primary health care is majorly maternal, newborn, and child health, right? The bulk of the services that we expect most people at that level to be accessing are antenatal, routine immunization, facility deliveries, and the rest. And so it made sense to work with MRHC as a partner because of their strong research capacity. Since then, we've also gone on to work with them. We have an ongoing project at the moment in Gombe right now, where we're evaluating the feasibility and effectiveness of a community-based group antenatal care program. Depending on where you are in some countries, I think in the US, it's called centering pregnancy approaches. In Nigeria, we call it the group ANC. which very much in line with what Prof had mentioned, really looks at taking services to where women are. As we know, many women don't come in to facilities to deliver. In the northern part of the country, it's as low as 10% of women who deliver in a healthcare center, right? And the remaining 80%, 90% will deliver at home. So the goal of the project we're doing with MRHC is really to encourage women at community level through these peer support networks to complete their antenatal care visits and hopefully link them to care. And, we've had a really good positive experience working with MRHC. They helped us to design the study, which is a mixed methods approach, looking at the program effectiveness as well as the fidelity of implementation. So far, early results are showing that there's very strong acceptance among pregnant women, caregivers, and even community leaders. They have given feedback around increased accessibility, but also the convenience of being able to attend antenatal care closer to where they live, which then starts to address some of the issues of, cost of care. Because when we say cost of care, it's not just the cost of paying for the service, but actually things like transportation to a health center, the multiple visits that you need to go, those are all part of the cost that they have to bear. We've also gotten feedback about the improved quality of care when they compare this to the traditional antenatal services that they receive. And more importantly, the feedback we've received, and most of this is again being generated by MRHC, our partner, is showing that one of the things women most appreciate is the group antenatal care model is providing emotional support to many of them, health education, and actually is fostering unity between the community and the healthcare providers who come to these communities to deliver services. So that even further strengthens the appeal and the potential reach that this has for underserved communities. So right now we're working closely with the policymakers in Gombe to take this data, break it down into easily digestible nuggets, and to work with the government to figure out how they can come up with more strategic interventions to scale this up, right? Taking into cognizance issues of funding, the need to also have robust monitoring infrastructure put in place, because one thing is to test an intervention, the next is to scale and to still ensure that at scale it continues to work. So far, I would honestly say that we've enjoyed working with MRHC, and not because this is their webinar, but because I find that our relationship has been very synergistic and complementary. We are not super research oriented, but we also do a lot of systems and we want to be able to measure the impact of our work. And, the benefit of having a partner like MRHC is to bring that core technical expertise in maternal and child health and ensure that we're designing the evaluation the right way. That then helps us to understand the effect and the drivers of the effect that we get from our program. So overall, it's been positive. I look forward to continuing to work with them. We continue to explore opportunities and we look forward to continue to work, to improve and advance maternal health quality and reduce deaths from preventable causes in Nigeria. Thank you.
Thank you very much for sharing the great work that you're doing. I'm seeing the applauses. Everyone is really excited in the chat box about the collaboration between you and MRH Collective. I think that is great work that is being done. Also talking about the group antenatal, you spoke about the group antenatal. I'm excited about that because I feel like that also creates community amongst the women. Pregnancy can feel very lonely for a number of women. So just getting to be with other women who are walking the same path and they can share notes and experiences, it fosters a feeling of togetherness and takes away that loneliness. So well done, Chai, and cheers to future collaborations. We hope that the partnership doesn't end anytime soon. So thank you very much for sharing your thoughts on that.
Thank you.
Thank you. Now we're also going to be speaking with a guest speaker who has done phenomenal work in terms of reducing maternal mortality rates. And I'm just going to read through a very abridged profile and just to also get a sense of how much work has been done and how important global collaboration is in reducing maternal mortality rates in Nigeria. Our next guest is a global women's health professionals supporting governments as they work to strengthen the quality of health services and improve access to care. She has worked in over 20 countries over the past 30 years on RMNCAH and has lived and worked in Nepal since 2001. She most recently led the Antenatal Postnatal Care Research Collective ARC project, which conducted implementation research on innovations aiming to improve quality and continuity of care in Nigeria, Ethiopia, Kenya, Malawi, Mali, and Pakistan. She's passionate about Group ANC and improving the experience of care for women and providers. She has an MPH from Johns Hopkins and School of Public Health. Please join me as I welcome the Principal Technical Advisor. Maternal Health, formerly at JPEGO. Please welcome with me, Stephanie Suhowatski. Now let's give her a very Nigerian welcome. Nigerians are known to be very warm people. So let's see even greater celebrations in the chat box as we welcome Stephanie. Hello, Stephanie. Good evening, Nigerian time.
Hi.
And joining us.
Hi, thank you so much. What a great opportunity. It's a delight to be able to speak with everyone today, and especially following Dr. Bosede and Funke's excellent comments so far. So thanks for inviting me today.
Thank you very much. I think a great way to start would be to get your sense of the numbers. You've heard the numbers, the maternal mortality rate numbers in Nigeria, the challenges, the work that has been done by MRH Collective in reducing these numbers. But let's get a sense of your initial thoughts regarding the numbers and why it's an important conversation to have.
Yes, I have been working in Nigeria since 2015. As Funke had mentioned, the very first group antenatal care study that was done in Nigeria, we had conducted. And I was really amazed at that point at the high levels of maternal mortality in Nigeria. And here we are 10 years later. And as Dr. Busedi said, the rates are still very high and the numbers of women dying are very high. And we're talking about maternal health and maternal mortality, but equally, Nigeria leads on newborn mortality and stillbirths. So it really is a crisis, I think, in Nigeria. And it's fantastic the government is recognizing that, both at the federal level and at the state level. And it's really incredible to see partners like MRH Collective and CHAI on the ground and really advancing, taking the leadership, taking the innovation, taking steps on a daily basis to try to save lives and improve the health outcomes for moms and babies.
Can you also share with us some sort of a global standpoint, a global reflection of maternal mortality, what we currently experience in Nigeria? You've worked in other countries as well. Is that the reality of other women in other countries in the world?
Yes, so I think there's some really excellent work that's been done over the past couple of years called the Exemplars in Health. And it's in the Lancet, and it shows over the last 20 years, they map out which countries have made significant reductions in maternal mortality and which countries haven't. And then they tried to unpack what has been able to drive the reductions. And the two countries that really were highlighted in 2023 were Ethiopia and Nepal. I've lived in Nepal for 20 years. And when I moved there, 6% of women had their babies in facilities back in 1998. And now 70% of women have their babies in hospitals or at a health center. So, there are other countries over the past 20 years that have made investments and commitments and progress in maternal health. But I think the challenge for Nigeria is we haven't seen the same investment, and I don't think we've seen the same level of progress. So it's time. It's the time right now for Nigeria to invest and for Nigerians to advocate for investments in women's health. And I think it can happen at facility levels and at the at the state level, at the federal level. I think this is really the time for Nigeria to invest. And it takes even, this really excellent example of the Miles model that Bosedi was talking about, even the community group ANC model that Funke was talking about. It's going to take, finding ways to reach women, either bringing the care to them or creating models of care that meet women's needs, that we offer services that women actually want. They'll come if there's something that they feel respects them, provides the quality of care that they want and they need. And so it's really great. I think we've already heard today some excellent examples of where we're innovating to make care better for women and better meet their needs.
Thank you very much for talking about that and looking at these innovative ways to make care better for women. Let's talk about the role that collaboration has to play in all of this. We've talked about the role that certain organizations have played. We did just hear from Chai. How important is it to have partnerships and collaborations from communities around the world to be able to reduce these numbers?
Yeah, I do think that partnership is the way to go. I don't think governments alone are able to resource. I don't think governments alone are able to come up with all of the ideas, all of the latest evidence, the latest thinking, the strategies. I do think partnerships are really the only way we're going to be able to solve this problem in Nigeria. And it's going to take NGOs, INGOs, we have, passionate physicians, we have committed public health advocates. It's just going to take a combination for sure. Especially we need people who are able to advocate for investments. We're going to need supply chain, to bring in the right commodities, to drive the cost down of certain commodities, to make sure that we have the right healthcare providers in the right places. I know the drain, the human resource drain in Nigeria is really acute right now. Doctors and nurses and midwives are leaving. And so we're going to need partnerships to figure out how do we either increase the numbers or how do we retain some of these skilled providers. So yeah, I think partnership for sure is the way to go. And Funke was giving some great examples of working at the community level. Chai is supporting some of that innovation. I think MRH is looking at the research and asking the questions and trying to create the evidence so that the government has an understanding of if they invest in a group ANC model at the community level, what's the benefit from that, right? Why should they invest? What return will they get? So that was a really nice example that Funke gave. And I think we have a nice example from the work that Chupaigo did under our ARC project. That was the Gates Foundation funded work that we did with MRH Collective. We did a study on trying to increase birth companions in facilities. This is like an evidence-based practice. We all know that it's better for women. We know women want to have someone with them in the facility during labor, childbirth, and postpartum. And then we had this really nice partnership working in both Nasarawa State and Kano with MRH and Chupaigo to integrate birth companions, to make some small changes in the facility, to have the providers in the state be supportive of changing some of the policy. I think that's another good example of trying to understand what women want and creating a partnership to demonstrate that it's possible. Small changes small changes in a facility can really make big changes in terms of the quality of care that women experience.
Thank you for speaking to the role that international partnership and collaboration has to play in reducing these numbers. And I like that you particularly spoke about certain policy changes that need to be made. For example, reviewing access to certain individuals in the care room, in the delivery room, and how women don't want to feel alone. I mean, I can imagine how very lonely it will be for a woman who's going through this transformative journey, this life-changing journey, and having to feel like she's doing that alone. In your experience so far, and I did ask Prof the same question, Professor Day, I want to ask you, what would you say are some of the challenges we've had to deal with here in Nigeria, some of the hiccups and just really the problems we've had to navigate in ensuring that we have stronger systems and structures, policies, and that we no longer see maternal health care as a privilege, but as a right?
Yeah, that's the million-dollar question. It's a great question. Thank you. I think the challenges, you can think of them at both kind of on the supply side, or you can think about the provision of care and how do we provide really excellent quality of care. And then we can also think about it kind of on the women's perspective or the demand side, and that experience of care. What do women actually want? And I think the challenges on the supply side are pretty tremendous. And it's going to take some substantial investment. I had mentioned before the lack of skilled providers. We really do need, qualified nurses, midwives, and doctors. We have a lot of CHUs, and they're doing amazing work, but we also need other cadres in the system. We need commodities. I think deworming tablets, for an example, are part of pregnancy care, and the rates still in Nigeria are very low. And we have a lot of new innovations coming out, particularly around postpartum hemorrhage. There's a lot of new medicines and supplies that are needed to improve the quality of care for every woman when she gives birth. And that's going to require a huge number of commodities into the system. And those cost money, and the government has to be able to pay for those. And then we have, infrastructure. That's the ambulances to move between facilities. That's the structure of the primary health centers. There's a lot on the supply side, but I think hopefully the government's going to make some of those investments, and we do want to make sure that we keep that experience of care. What women really want, what are their needs? They need, as Dr. Bosede said, they need education and they need support, and they need some linkages, right? So those are all really important. And it's, even if we focus so much on getting the health system to provide the quality care, we really want to make sure that we keep what women want, like that experience of care for women and their families, really close to heart, and make sure that we don't lose that as we're trying to make the health system function better. Really thinking about experience of care is really important.
It really is important. Thank you for speaking to these challenges. And I'm really glad that it would seem that you and Professor Bosede spoke about different kinds of challenges. So it shows that there's a lot of work that we need to do in terms of, being able to render this sort of support, how very financially demanding this support is. And I'm sure that we will talk a little more about how every one of us, individuals, governments, policymakers, can be a part of it. But we're going to take a few questions. If you can, please, there's a top right corner of the chat box. Drop your questions there. We're going to play a video as well to share with you the work that we've done at MRHC, and basically just to let you know that what we're doing here is not just about talking. We are very particular about seeing results. But first of all, can we please give Stephanie a round of applause in the chat box to say thank you. Thank you for your time. Thank you for the work. And just to say well done, because part of the work that we're doing, we have to encourage the people who are at the forefront of ensuring that we're redefining the meaning of, maternal health in Nigeria. So thank you so much, Stephanie, for the great work that you're doing. And just to, announce, I'm going to bring back Stephanie and Professor Bosede to please help answer the questions that we have. We're going to take a few questions, so I'm going to take them in order of priority. I can see that some people have started to drop in the questions. I'll take as much as I can. But first, let's get to see a testimonial video from a beneficiary from this, from the work that we're doing here. So let's take a look at this video, and I'll be right back with more with the Q&A.
All this, they check up on me right from when I was pregnant till now. They're still checking up on me, and when I put to bed, they give me some money to take care of myself and my baby. And I would like to say a big thank you to Mama Beans, because they have cared for me right from my pregnancy till now that I'm with my baby.
My name is Mrs. Ogundenison. I meet Mama Beans when I was pregnant at Shomulu Akoka. So they done well for us. They give us supplement drug when I was pregnant. They always come to our PhD to come and check on us. They give us money. So, and then delivering is free. I want to thank Mama Beans for the money, for the care, for the support. We really appreciate.
My name is Akindasha Oluwafunlayo Kekiola. I met Mama Beans at Ilopedu at Ayutuga. They take care of me, they gave me drugs, they pay for my deliverings, and after deliverings, they gave me money and clothes with pampers. I thank Mama Beans for all their support, and may God bless them.
Fatima, Mama Beans, the time I get pregnant, the Mama Beans see me for road, give me the paper for call. I reach there, they tell me say where I dey stay. I say Abati. I reach the hospital, they check me, they give me tablet. They say every week they come see my body. Then they give me drugs, I dey drink, I dey see my body well. Time reach, I born, I dey happy. Mama Beans try for me with the scanning test, with the tablet where I take, they pay everything. There's free, and then dash my baby clothes. I dey for happy, now I make I call plenty people safe, they come. Thank you for Mama Beans.
My name is Lovina.
Thank you so much for sharing that. Really great work there. You could see all of them talking about the impact that Mama Beans has had in terms of them being able to get access to free drugs, free support in healthcare. And there's so much more that can be done. We'll share with you shortly how much impact we've been able to achieve. And when you decide to partner with us, what impact you're able to get. But again, I'm going to just bring back Prof and Stephanie, Prof Bosede and Stephanie, please, if you can please join me back. I'm seeing a number of questions. Somebody said that Stephanie raised a very valid point, that there's been 10 years of consistently, trying to prevent maternal mortality, but the numbers have not come down as much as they should, according to, one of the questions we're seeing here, and they are asking, isn't it time we probably rethink our approach to combating maternal mortality? Stephanie, I believe that question is for you.
Yeah, I mean, I had mentioned in my comments that there is this exemplars in health, and Nigeria is in stage 1, and other countries have moved closer towards, stage 5 is all basically like the high income countries. And so that model, the exemplars in health, they break down what does it take to move from stage 1 to stage 2 or stage 2 to stage 3. So I'm happy to share the link to that article. I think it is helpful. I think there were some other comments in the chat that were thinking about, free healthcare, using insurance schemes. Yes, I think at the same time, there needs to be investments in strengthening the health system. We need better quality care, and that means providers and drugs and referral systems and all those great things. So yeah, it is the time to invest, and there's good evidence. There's good evidence for the Federal Ministry of Health and for the states. The state PHCDAs or boards. There's evidence there, and I'm happy to help. Get access to the Exemplars in Health series for everyone, and happy to provide any additional resources we can to make sure that, we all like to work from evidence. That's how clinicians are trained, right? Take the evidence from clinical trials and we apply it. But there's really good evidence also on how countries have moved to reduce maternal mortality.
All right. Thank you very much for sharing that, Stephanie. We can see another question from Abbas Bolahon, who says, I appreciate the work Dr. Bosede Afolabi is doing. What roles do you feel traditional birth attendants, TBS, and CBA can do to reduce the maternal death. We have done a mapping in Oyo State, and we realize a lot of women patronize TBA. Lots of bad referrals come from them. Any experience in Lagos? This is from Dr. Abbas Agbolahon.
Thank you. Thank you very much for that question, Dr. Abbas. So TBA is traditional birth attendants. They are people that live in the community of these women. They are not skilled healthcare practitioners. They're people that have, delivered, babies of people's grandmothers and so on. And some of them don't actually have any real training or experience at all. Some of them have some bits. They are difficult to regulate, but Lagos State has tried to register them. The only problem is that a lot of them are still under the radar and are not actually properly registered. And so, some of them are called anti-nurse, not even just traditional birth attendants. They're all the same thing, people who don't have the actual training. The roles they have to play, because there is poor access. There was a community we visited on one of our outreaches where you could only take a canoe to get to that community. You couldn't, there was the nearest hospital, there was a primary health center within the community, but it was only manned by one nurse. So they wouldn't open at night. So if a woman has to deliver, she has to take a canoe, first of all, a tricycle to the edge of where she'll take the canoe, then a canoe all the way to the other side. It's difficult. It's easier for her to go to the TBA that is next door. So what to do with traditional birth attendants is, one, let them know their referral limits. Let them, let them learn, train them to know their limits, to know when, they can, a woman can easily deliver or not, to refer as much as possible. If possible, they should refer. But if they can't, if they feel that they would have to take some of the deliveries, ensure that they know those ones that are, ever so slightly difficult, and immediately refer them. Another thing is to register them and try to keep registering and re-registering them so that they can be on a database. Ondo State did something once where they actually gave them incentives to refer, all sorts of different ways. It takes so many, the health, maternal health area is very, very complex. And so it needs a lot of different health system changes, just like Funke was saying. And one of them is this part of delivering outside the hospitals, which includes sorting out traditional birth attendants. Thank you.
Well, thank you very much for, talking about how, because I'm seeing in the comment section, there are a lot of people asking about traditional birth attendants. And there's also someone who says, and this is Bola Ufi. Bola Ufi says, why can't we have free maternal care? What does this question
Yeah, I think that's the way to go, basically. And I think that the government is looking at this. It's part of the MAMI project. That's the plan. It's not fully, that's the thing, for any initiative, it does need time to be rolled out properly. And I'm really, really hoping that this one would be rolled out properly. That's the plan, to make childbirth free. Because if it is, then women will eventually go. There's some women who will still go to the TBAs at the beginning, but after some time, when the what's the word now, momentum catches on, they will move. It's been done before. It's been shown to work in the country. It's just the sustenance, the sustainability that will make the difference.
All right, thank you for highlighting that. Stephanie, I want you to speak to this to answer this question. It's from Icha Pacheco, who says, in the US, we're seeing a return to traditional birth support through doulas and midwives alongside medical care. What global strategies or policies do you think are most effective in protecting and integrating this kind of culturally rooted care, especially as systems try to medicalize or regulate it?
Great question. Yes, so in the US, we do see there has been a shift away from fully physician-based care to midwifery care, and wholly support the same for Nigeria. I think globally, that's the strategy, to really invest in midwives. And we know with the out-migration in Nigeria of nurses and midwives, this is a challenge, but it certainly should be part of the 5-year and 10-year strategy for Nigeria to invest in midwives. The idea of doulas is interesting. Doulas are essentially like a paid birth companion. It's someone who has some basic training. I have a number of friends who went through doula training. So it's kind of like a slightly trained birth companion. Interesting to think about it in the Nigerian context. I think I would start with trying to allow just birth companions, a family member in with women routinely as part of universal, access for family members. I would promote that strategy probably more in Nigeria. If you get to a point where you've got 70-80% of births happening in facilities, then maybe a doula strategy makes sense. But in the short term, just letting birth companions in with a family member, husband, mom, mother-in-law, sister, friend, I think that would be a really important addition into the strategy. Good investment for Nigeria to make that happen.
Thank you very much, Stephanie, for that answer. Ayokunle Faniku from Ingress Health Partners Lagos says, and this question is directed at Prof. Bosade, says, the MILES model is great. Are there any challenges you want to share with this model? And is there any referral and feedback mechanism in this model?
Thank you very much. Yes, there definitely were challenges, as with all initiatives. The particular ones we faced were things to do with the women, sometimes, the access during out of hours. So one of the things we tried to do to mitigate those was to get the cyclists, the kekema, what we call them, tricycles, engage them and get the people in that area to have the numbers of those cyclists so that they can help with transportation. It was a difficult one, but it helped when we tried to do that combined engagement and have their numbers so that they can call in the middle of the night as much as possible. For health insurance is another challenge. The fact that most of these women were not enrolled on any form of health insurance, and they weren't aware as well of, even though it's available, their awareness and their trust, and that trust is a very big thing, was not there. So we try to help bridge that gap as well with the education part of MILES by, letting them know that this was available and letting them understand why it was important for them to access this insurance. The part that was the most difficult one to break, and that was why even with all we did, we had 80% delivery rates in the hospitals as opposed to what usually obtains of about 60-something%. There were still 20% of people that did not deliver in hospital, despite all our advocacy, where the deeply rooted beliefs that influence the health-seeking behaviors in some of these communities. Slowly but surely, though, with the continuous education, including those around them, not just the women themselves, but their family members, we feel that will eventually resolve, especially if the cost issue is also reduced. Thank you.
Thank you very much, Prof, for speaking to that. I think I want Stephanie to speak to a comment. It's a comment or a question. It's both a comment and a question that someone has shared about how we can reduce on infant pregnancies, how we can reduce pregnancies among younger people, and then talking about how mothers with HIV are the ones that suffer the most when it comes to being able to access healthcare. So I want Stephanie to speak to that, and then we can take 2 more questions before we probably draw the curtain tonight, and then let you know how you can be a part of our work.
Sure, thanks. So, adolescent pregnancy is an enormous problem in sub-Saharan Africa. There are certainly communities where adolescent pregnancy is high. I think communities in Nigeria where child marriage is quite common. It is certainly a priority. We see that maternal mortality is very high among the 15 to 19-year-olds. And so I would say for Nigeria, having strategy to really figure out which communities have the highest rates of adolescent pregnancy and making sure those first-time moms or those first-time couples really get the support and the care that they need. I am sure in the mama-based model, if you're working with the poorest and you're working in the informal urban settlements, I'm sure reaching out for those adolescent girls who are her moms would be a priority. Yeah, definitely. If we want to see maternal mortality reduced, then we just want to see, healthier communities. Adolescent pregnancy is a place to focus. HIV obviously is another very vulnerable population. Moms who are HIV positive need support. They need extra support. They need all the support of a pregnant mom, and then they have the stigma, and then they have the health concerns. And we want to make sure those babies get that they get PMCT, CT, so we aren't having any transmission. So definitely, those are two high priority populations. We need to find them when they're pregnant and make sure they get the care they need.
Thank you so much, Stephanie, for speaking to that. We need to highlight how important it is to do what we're doing and how we can't do it by ourselves. I'm just going to run through a brief explanation of what your money does when you give what we're doing. So with as little as 5,000 naira, or if you say $3 or £3, 320 euros, you're giving or you're helping to cover the cost of mobile health messages and follow-up calls for one woman. And importantly, that when it comes to this, we value being able to share data. Here in Nigeria, we have those messages and those reminders that come in to let you know to go get checked. And sometimes that's all a woman needs or a mother needs to encourage her to take that next step. With 10,000 naira, that's $7, £5.50, €6.50 pays for a woman's basic lab test and antenatal screening. With 20,000 naira, that is $14, £11 or 13 euros. It supports full antenatal care visits and facility registration. And with 37,000 naira, that is $25 or £20 or 23 euros, it sponsors one woman's entire journey from registration to safe delivery and postpartum follow-up. So imagine what you're doing. If you give as little as 37,000 naira for one woman. Imagine how much every one of us everyone on this call, if we all gave, imagine how much impact we'll be making in the lives of many of these women who are in rural areas, underserved communities. And in case you're wondering how to give, you can give. We have those of us, that's why I mentioned the Nigerian naira, I mentioned pounds, I mentioned dollars. Yes, it's not necessarily a monthly donation, as often as you can. I'm going to invite Prof to speak to it, but if we can please shoot the flyer that has the details for those who want to give. And I'd like to ask that you please take a screenshot when we're done with this, revisit the flyer. And if you'd like to give us, to support these women in naira, pounds, euros, please take a screenshot of this flyer and ensure that you be a part of this. For those in the US who like to donate, the account tag is bossede at mrhcollective.org. And we're going to please type this in the chat box. bossede at mrhcollective.org. The account name is Maternal and Reproductive Health Research Collective. So I'd like the media team to please shoot the flyer. But before then, I think we have another question. Someone here shares, I think there's a certain Bilikis's message they're supporting. Okay, feedback and referral from Mama Base. We linked the PHCs with the nearest secondary level hospital and got the CHWs to ensure that the women who needed referral from PHC went to the appropriate secondary level hospital and also traced them there. Okay, this is in response. Yes, Prof has responded to Ayokunle. Yeah. Great. We're also seeing a few more comments here. Someone says, does Mama Model cover neonatal care as regards?
I want to answer that.
Okay.
Yes. So when we say 37,000 naira per woman, it doesn't mean that, every woman will need that amount. There will be some women who will need very little. So by the time you combine, all the different needs, including those that we had to pay for emergency healthcare for even cesarean section, because only very few women will need, hospital stroke emergency care if they go through antenatal and if you do the prevention appropriately, it evened out. So we were actually able to pay for some prematurely delivered babies, but there weren't many, I have to point out, because if you have a really premature baby that is delivered very early, that's going to need some special care, special baby care unit, and that is quite expensive. But basically, our neonatal, I mentioned our maternal mortality ratio being quite low earlier on. The neonatal too was very low. We had 18 per thousand, as opposed to the 40-something per thousand that is the national figure. So it's actually, Mama Base was a very, I was very pleasantly surprised myself. I did not expect it to be that effective. And even if you say perhaps we picked the women that were well already, or perhaps we didn't go to the right groups, which is not true. But if we look at it that way, even with, you know, healthy women, you would still have, you know, maternal deaths, you know, in this environment that are more than what we had. So I believe that the model actually works, and we were able to do this with help and with using very little resources at the end of the day per woman, when you cone it down to per woman. Some of these funds was, of course, used to also pay the community health workers and mobilizers. And part of why somebody asked about midwives, the unfortunate reason why we couldn't have so many midwives actually being in the communities, as Stephanie said, we have such few midwives and nurses left, you know, as well as doctors. Everybody is leaving. And that's a key thing that, you know, the government also has to address and is currently trying to address. We need to be partners. We need to, you know, help make these things happen. And that's why we've carried this on our heads, as we say it in Nigeria. And like I tell people in MRH, it's our life's blood. I've been talking all the time, but MRH is quite a sizable organization. We have about 30 full-time staff and over 100 part-time staff. And the full-time staff, some of them are on here. We have the acting ED, we have the COO, we have quite a number of people doing all this wonderful work that we're talking about. I'm just the face that is been talking at the moment, but they do all the work and they come up with a lot of really bright ideas to help get these women better. We also have a great board that has been very supportive and moving this organization forward. So
great. Thank you very much, Professor Lee, for speaking to, you know, that in terms of what the financial implications are, and, you know, how they can help in, you know, how our donations can help in making this work easy. I can see that the link to give is put in the chat box, so please, you can also take a screenshot of this if you'd like to contribute and assist with the work we're doing. It's not just money that we need. There's also the volunteer aspect. You could hear when our representative from CHAI was speaking, and she was talking about how they create communities for these women where they have group antenatal sessions, to let you know that for all of this to happen, there are people who oftentimes volunteer their time and their service to making this happen. So if you would like to volunteer as well, would like to ask that you please reach out to us, send us a message. We have our social media handles. We want to ask that you follow us on all of them. We put out all our information there at MRH Collective on all social media platforms. So I'm seeing people who are asking, great, for contact information. And I'm sure that I'll give Professor Wasade the last shot on that. But before then, I want Stephanie also to speak to the importance of artificial intelligence. I'm seeing a number of questions. Someone says, on collaboration and mentoring, our research team is closer to a research grant on human factor and PPH management in Nigeria. Is Prof and her team available if contacted? So that will be a question that Prof will answer finally. And then we also have someone who's talking about collaboration using, they're setting up AI-powered tools that help healthcare providers detect pregnancy complications early, such as preeclampsia, fetal anomalies, and obstetric hemorrhage, ultimately reducing maternal and infant mortality in Africa. So they're looking to explore how Tamela AI can collaborate to drive greater impact. So they're asking if we'll be open to collaborations and partnerships. So I want Stephanie to quickly speak on the importance of artificial intelligence as we're moving into the artificial intelligence era. How important is it for us to use AI and the data that AI provides and support that AI provides to reduce maternal mortality rates? That's my final question to Stephanie. And then to Prof, my final question to you would be, how people can reach out for those who want to partner, and just to sort of, once again, reiterate why it's important that we get many people on board. Over to you, Stephanie, and then Professor Bosede.
Great. That is a great question. And I think where Nigeria is right now with Choose basically providing most of the primary health care, I think AI-enabled tools are a really smart investment for Nigeria. They need to be tested, but I think given the lack of human resources we have in the system, whatever tools we can generate to support Choose to make better decisions, to help even the lab techs to make better decisions, to help the data clerks, use data to understand the trends in different facilities. I think AI is really a powerful tool, and I think Nigeria would be very smart to take advantage of it. So it needs to be done in a thoughtful way, but when you don't have a lot of providers and you have lower skilled providers or less experienced providers, that is exactly where AI can really contribute. And I know we already have like SMS tools and other things to generate. I think that's probably less, for me, less of a priority in Nigeria, but really helping support providers. Because there's few of them and they're not very skilled. So I'd be happy to talk with them as well. I'm sure Dr. Bosede would like to talk to them as well post-call.
Professor Bosede will speak to that, and how they can contact the both of you for those who are looking to speak about collaborations from here on. The floor is yours, Prof.
Thank you very much. And I really thank everyone for having, listened and, joined. It shows that you care, and that's really the beginning. You can reach us on the email address written there, info@mrhrcollective.org. But in case you forget that, it's MRH Collective. So just go to the website, mrhcollective.org, www.mrhcollective.org. So it's .org and not .com. So which you just think about it is an organization. So www.mrhcollective.org. All the information you need is there, including the email address to use and anything else you want to find. Thank you very, very much.
Thank you very much, Prof, for speaking to that. So if you'd like to partner, you want to reach out, there's anything you need clarification on, the website is www.mrhcollective.org. That is the website. Or if you'd like to just send an email, send it to info@mrhcollective.org. Thank you. I can see people in the comment section. Someone just said she's just giving. Thank you so much to those who have just given to us. We are very, very, very open to international collaborations. If you'd like to give from the UK, the US, wherever in the world you are, you can give. There's a give link. Can we please put up the give link? If you'd like to give, please click on that link. And any other information that you don't have, we'll be putting on our website, and also resharing highlights from tonight's conversation on our social media platforms. Follow us on Instagram on our website, on Instagram, at MRH Collective as well. I just want to say on a final note, would be that to remind us that it is not a sprint, it's a marathon, it's a long journey. We are all going to be a part of it. It's not something that can be done by one person. It's not something that can be done by the organization alone. We all, everyone here, key players in the healthcare sector, individuals who are just very moved by what is happening to these women. We all come from women. We all have mothers, sisters, friends who may decide to walk down the path of being mothers and will be impacted by the choices that we make. So I want to applaud those who have been a part of this and to implore you to please not, to not look down on this, to not ignore, to not look the other way. Let it not be just one of those things. To ensure that we are a part of this work. We help to spread the word. And something as little as taking a screenshot here and posting on your Instagram story so that people can see what is happening, saying, you've just been a part of this wonderful webinar and you like to get the word out there, even on your Twitter, on your Facebook. For some people, the support that we will get will be from one of your followers on your social media platforms. So please, want to appeal to you and to urge you to not just take this as one of the webinars you've attended, but we would like to see actions taken from here. Thank you to everyone, to all over 193 of you who have stayed till the very end of this webinar. First of all, I want to say, give yourselves a round of applause in the chat box. Thank you. I'm just going to give a quick shout out to as many people as I can. I can see a number of you sharing where you're watching from. Ezine Mba, Abuja, Nigeria, PhD student of maternal health. Thank you for joining us. Dr. Wale Folaromi, a neonatologist in Pennsylvania, US. Thank you very much for joining us. Dr. Oyewole Asowata from North Carolina, US. Thank you. Thank you, everyone, for joining us today. We look forward to seeing you at our next webinar. Do not be strangers. Engage with all our content on social media where we share. Do well to please reshare on your social media as well. Can we all please also say thank you to Stephanie and to Prof. Bosede for the amazing work that they are doing and continue to do. And we all here are pledging our support. And yes, to the fantastic MRH team for putting this. It took a lot. There are people behind the scenes, who have made this work a success. Our technical team, Mrs. Jumoke Oke, a number of people who have worked really hard to make today a success. We want to say thank you. Thank you to all of you. And I want to say thank you. Thank you, Ma. Thank you. Thank you for the honor of having me be your compare. My name is Olive Emodi. I'm a TV host with News Central Television. I'm very, very excited to have been your compare tonight. We look forward to the next time gathering to be able to say, this is what our target was, and this is how we have surpassed our target. And we can only do that with your help. So thank you very much for joining us, everyone. Have a safe trip to your beds for those of you watching from Nigeria, and for those of you from maybe the US or other zones, enjoy the rest of your day. From us here in Lagos, Nigeria, it is good night. We'll leave it running for a few more minutes whilst you're all dropping your chats, your comments, saying the thank yous. Thank you very much.
Put the flyer back. Yeah, thank you.
Yeah. We're just also going to put the flyer back for those who would like to take screenshots of how you can share and how you can be a part of giving to MRH Collective. Thank you, everyone. Thank you. I can see. Thank you very much. Thank you. Okay. So we will see you at the next event, the next webinar, and we will see you on social media as well. And we will see you in your givings. Yes, thank you. Take the screenshot. For those who are asking, you can give from anywhere in the world, US, UK, wherever you are. There's a www.give.ng/mamabase link that you can give from anywhere in the world. And just in case you're not very certain as to what the details are, feel free to reach out to us by visiting our website as well. From all of us here, it's a good night and enjoy the rest of your day. Bye-bye.